Yeah, it's not pulling through. That's why we did this. Yeah. Hi, Colby. Hi, Farisha. Okay. Well, going to try and start basically on time today. I'll give it another 30 seconds or a minute, but it's great to see everybody here. It's a good turnout and happy to answer hopefully lots and lots of questions. That's what this is designed to do. For those of you who don't know, I'm Dr. Andrew Heyman. I run the fellowship program at George Washington University in integrative medicine in our Department of Health Sciences. And for about a decade, I was the director of academic affairs for the American Academy of Anti-Aging Medicine. And my clinical focus has been these fatiguing illnesses such as SIRS and sort of related conditions. As many of you probably know, I published quite a bit in the area, especially with Dr. Shoemaker. I co-edited the textbook on CIRS a few years ago, and continue to be very active in the research space, asking, kind of hard questions on what do we know, what do we don't know, where's the science today, what are new clinical insights that might be derived from that new science, and how do we help people that are stuck? This is an issue. I think a lot of you feel that way in terms of feeling stuck or only making so much progress. And so I think, there's a whole new world in terms of being able to measure different aspects of our biology that we never could before. And I like the discourse. I like to have interaction with you guys and, get good questions and sort of work through difficult issues and specifics. I've treated thousands of patients and, kind of seen the good, the bad, and the ugly in that regard. And so I'm, grateful that you all are here. I'm grateful for my Beyond Mold team, who's been incredibly supportive. Today, we are hoping to also include, and we will through the chat, some of my colleagues who are experts in the subject as well. So we have additional team members that will be answering questions if possible. Lori Bain and Michelle Fisher. Lori's been with me for over a decade now, not only administering my clinic, but also as sort of a right-hand woman with respect to patient care. She's a health coach in her own right, but I feel like that term doesn't do her service in terms of her deep expertise on the subject. And then also Michelle Fisher, who for over a decade now as well, has been involved in investigations and remediations of contaminated environments. And so I wanted to begin to sort of expand your exposure to our team with respect to sort of the breadth of our expertise, and hopefully answer all sorts of questions today that might be on your mind. And there are, of course, many. Last time when I did this, some people asked, well, what's your story? And, mine is just like yours in the sense that I was at University of Michigan in medical school, and I was able to spend a month in my last year of medical school in Virginia. And at the time, I was training for an Ironman and was on a run, came back home and noticed something on the back of my leg, and it was a tick. It was an embedded tick. And as many of you have probably found out, as much as we know next to nothing about mold, we know just as little about Lyme disease. And certainly I didn't learn anything meaningful in medical school and ignored it. I just sort of picked the tick off and went on my merry way. But my health began to decline pretty soon thereafter in unexplainable ways. And I was used to being very fit and sort of, nothing really bothered me. But I noticed that my health was changing. And over time, my body almost became this foreign object that I didn't recognize. It was distressing, but I sort of wrote it off as, well, it's medical training. And, we all go through this and I'll get better. But I didn't. And in some ways, I got a lot worse. It wasn't until a decade later that I completed all my training. I'd been on faculty at Michigan and then moved, actually, ironically, to Virginia, and noticed that a lot of my patients were talking about symptoms and problems. And I realized that I felt the way that they felt. And so I did some testing, and sure enough, I was positive with Lyme disease. And I didn't even need to guess. All of my tests were positive. And so I was very aggressive with treating myself for Lyme for at least a year with lots and lots of antibiotics, but I didn't really feel much better, maybe a little bit. And that was my first lesson, is that even when, you do aggressive therapy for Lyme disease, there's usually a lot of other things that have to be dealt with. And then I'd heard about Dr. Shoemaker on the Eastern Shore, not too far from my practice. We got together and immediately had sort of a mutual understanding. And so I started doing research with him and collaborating. This was back in 2014. And I ran the classic quote CIRS labs on myself as well. And they were all through the roof. And I realized that I was also reacting to my environment. I think a lot of you can appreciate this, that there's these sort of knock-on effects that once this illness starts, we tend to start reacting to all sorts of things. For me, the initiating event or priming event was Lyme, but then, it led to mold. And, I realized even working closely with Dr. Shoemaker for many years that there still were a lot of issues unanswered, both in terms of how we understood this illness, but also what to do about it treatment-wise. But, I also wanted to kind of adhere to the model. So if you look back over the past, almost decade, I've published most of the papers with him. And so feel very intimately familiar with the whole concept of CIRS. I'm the only other physician that has ever taught with him professionally, and feel very aligned in some ways with the model. But I also, having a research background, understood that the world was sort of moving on as it related to our deeper understanding of what this sort of category of illness really represented. And around 2017, I began doing some co-teaching with Dr. Navio, who was publishing on the cell danger response. And I realized that, his work in mitochondrial metabolomics really was, I think, laying the foundation for what we now know today in terms of how people get sick and potential a roadmap for recovery. So some of the requests today was, how do we kind of break down the cell danger response and better understand it, but keep it simple? And where does CIRS sort of fit into that idea? But also kind of open all this up for live discussion. I think that's where the rubber hits the road, and that's where we need a lot of help and support. So I have a set of slides, every aspect of your physical health, but it also reaches into one's mental health and emotional state. It often influences our self-concept, our potency in the world, our relationships, meaning and purpose, and a sense of safety. Our bodies are not safe. Our minds are not safe. Even worse, loved ones in some ways don't understand us, so we feel very isolated, and therefore relationships in some sense feel unsafe. The medical system has by and large rejected us as a community. It refuses to acknowledge that this is a real illness. So trying to deal with your local friendly doctor can be arduous at best. And so the system feels unsafe. And even worse, our homes, which is often the source of our misery, our sanctuaries, unsafe as well. And at some point you kind of wake up and realize, where do I go? Who do I talk to? Who's going to help me out of this mess? But with all that being said, I do think that if you can at least understand the cell danger response, it offers a model for how to look at this illness through fresh eyes. And it also builds on our knowledge of CIRS, but expands and deepens it in meaningful ways. And so the cell danger response is really an architecture built around how the cells react to dangers and threats. And mold is just one threat among many in our lives. And what's interesting about Dr. Navio's insights, when he first started publishing in 2014 in Mitochondria, what he articulated was that, in fact, when danger signals arrive to the cell surface, instead of going to the nucleus, which is always considered sort of the brains of the cell, that threat signal instead goes to the mitochondria. And it's the mitochondria that orchestrates these cellular responses, that in fact, it's the brains of the cell in many ways, especially when the cell is under threat or stress. That alone was an enormous insight in terms of understanding where the signals are coming from with respect to how the cell is reacting to these threats and managing them. For many years, if any of you have sort of a biological background, you know that we were taught the mitochondria control energy production. And instead, what we now know is that it's really more about energy management. And there are sort of two modes the mitochondria can be in. They can be energy plants, where they, yes, produce a lot of ATP that serve the needs of cell function, or the mitochondria can shift in the setting of a threat and become a battleship. And battleship mode is a very different expression of the cell, and one that is profound in its ability to basically orchestrate all sorts of cellular processes and responses. It's this battleship mode that we really care about. And so when that cellular threat occurs, the mitochondria go into this altered state of effectiveness. And essentially what it's doing is turning on this built-in survival program, this very sort of predictable procedural reaction to whatever threats are in our environment. And just like a house, so if you imagine your body or your cells or a house, mold is what can set it on fire. And so too can actinomycetes and endotoxins. But beyond that, all sorts of other exposures can do that too. Infections can do it, like Lyme disease and COVID and reactivated Epstein-Barr. Chemicals such as organophosphates and phthalates and dioxin and PCBs. Heavy metals can do it, like mercury and arsenic and cadmium. EMFs, as well as physical trauma. So traumatic brain injury or car accident can initiate the fire. And then even finally stress. That emotional stress and a history of psychological trauma can also initiate the same sort of transition to battleship mode. And battleship mode is originally characterized by turning on inflammation. So the fire starts in the body. Now, this is meant to be adaptive. And over time, as the cell goes through its normal reactions to these threats, we're supposed to sort of deal with whatever threat that is. If it's a virus or bacteria or mold, that the threat goes away and the inflammation should return to normal. But remember that fire is probably burning down elements of the house, basically aspects of your health. So the mitochondria shift into the second phase, the CDR2 response, which is, okay, we have to rebuild. And that makes a lot of sense. Many of you know this in terms of neuroquants. You know, if you've ever done a neuroquant, say, yep, the fire started burning down my brain. And then finally, once the rebuilding is complete, it's time to move back into a safe home. But that requires very specific signals. And so this orchestrated response is a this orchestrated response is really important. And I'm getting a message. Should I go back, or can you see this slide? So I'm going to assume you can see this slide. So I'm going to keep moving forward. So let's go to CDR1. So the house is on fire. We have an exposure and the fire is raging. And so we have this innate inflammation. And this innate inflammation injures the brain, it injures the heart, it injures the gut. And we also need to understand that nothing can be rebuilt until the fire is put out. I see this all the time in clinical care, where one of our measures of fire is the visual test. But practitioners can at times push patients through a treatment process, even when the fire is still burning. And one of the great insights that we now know about how the mitochondria orchestrate these responses is that they happen in a very specific sequence. And the mitochondria will not progress from one phase to the next until there's sort of a satisfaction that certain criteria are met. That we don't progress to CDR2 of rebuilding if the fire is still burning. And that means we have to be very clear about understanding what these active exposures are. Are they still present? And is the fire still going? Now, there's something that's really important about understanding this initiating event of the fire, that it doesn't just go from the cell and down to the mitochondria. There's a little strip of signaling that intervenes between the two, and it's called the integrated stress response. And what happens is this integrated stress response is what's the sort of intermediary signal that turns on the cell danger response. And what's happening is there's a molecule called EIF2A that becomes turned on. And this is what sends the danger signal. Now, how do we turn this off? There's another enzyme called GAD34. And GAD34 is the brake that turns off the danger signal. So here's something that's fascinating that we're now learning. Even if you remove the mold, even if you reduce the chemical load, even if you detoxify the heavy metals, even if you reduce the sort of total exposure load, the integrated stress response can remain turned on. And so one of the ways that we can help people move forward is not just by removing the cause of the fire, but we also need to deal with this additional danger signal. And there are now specific treatments that we can bring to bear to do that. And there's also measurement tools to know whether or not this is turned on. And these are called MitoCondrial. So in terms of the inflammation piece, and if we break it down with respect to markers, some of them you're familiar with, like the visual test and MMP9. It turns out MMP9 is really one of the only classical inflammatory markers within the CIRS compendium. And I'll show you where the other markers fit. But MMP9 is really one of the only ones that we look at. In traditional medicine, we look at HSCRP. Even the presence of reactivated viruses can tell us whether or not this inflammation is occurring. And then there's something that's not necessarily measurable, but we know this is happening. Macrophages, which are the thugs of the cell or thugs of the immune system, become very activated and start producing lots and lots of inflammatory proteins. Now, again, one of the consequences of this ongoing inflammation, of the fire that's raging in the body, is destruction. And that's why we see changes, not just in the brain on neuroquant, but we see changes in the vascular system and the gut. Anywhere there are special barriers, we see barrier loss. And that's where this gets very interesting, because in the CIRS nomenclature, there's a couple markers that I'm going to get to that you should have an aha moment of, now I understand why these markers become abnormal, which I'll get to in a second. And then we can also see as a consequence dysbiosis, where we see disruption of the normal microbiome. And that can include overgrowth in the nasal passages, MARCoNS being one, and then ultimately injury to the critical tissues and organs like the brain, the heart, and the gut. So CDR1 is the house that's on fire. And remember, we have signaling to the mitochondria, and inserted into that is the integrated stress response. In addition to this, we then, if we're able to put out the fire, we then move into CDR2, which is the construction crew arrives. And they're there to clear the debris and repair the damage. This is busy, noisy work, but it is healing, and it's supposed to not be harm. So CDR2 is this sort of very vigorous rebuilding phase. Now, there are 4 elements to what's typically going on during the CDR2. The first is a construction crew arrives at the scene of damage, and its job is to lay down new tissue. Now, here are some familiar markers to you from the CIRS perspective that you might not have thought of this way, but the clue is in the name. TGF beta 1, VEGF, transforming growth factor beta 1. When the peripheral tissues are being injured, TGF beta 1 goes up. It's part of that repair crew. When the lining of the blood vessels are injured from inflammation, VEGF goes up. It's part of the repair crew. Now, we also know these can be exhausted over time, especially VEGF, that the cells produce less and less of these growth factors as if the fire keeps going and the reserves are wasted. In addition to that, we also know the body produces more tissue and growth when it's using sugar or glucose as a substrate instead of oxygen. And so this shift into burning sugar is a very important recognition. Simultaneously, there's a shift of macrophages, and they go from the M1 thug to an M2 cleanup crew. We didn't know until recently that there is that transition from M1 to M2. Interestingly, that's where the newer treatments called SPMs, or specialized pro-resolving mediators, play a role. These are derived from fish oil. A lot of the original research was done at Harvard in the early 2000s, and they merely asked the question, how does the immune system turn off inflammation? Well, one major way is this shift in macrophages. And it turns out the signaling molecules that are really important to tell the macrophage to not be a thug anymore are called specialized pro-resolving mediators, or SPMs. I did some of the original research with Metagenics on this. And so these are derivatives of fish oil, and they're called resolvins and protectins and myrisins and lipoxins, and they help that macrophage transition. Now, remember I said there's an alternative energy supply. So imagine your construction crew to be really active and vigorous relies on a different sort of energy than oxygen. So oxygen is the most efficient. That's what we see mitochondria normally producing, and that's when we have lots of energy. But instead, the construction crew relies on this alternative energy supply. So interestingly, the cells shift with respect to now being dependent on burning sugar or glucose. This is called the Warburg effect. It's called aerobic glycolysis, and it means the cells are not producing as much energy in terms of ATP, but instead shifting into growth and repair. Now, this alternative energy supply is good for the construction crew, but it's bad for how you feel. We see this on GENIE in section 1 and in section 2. If you're familiar with GENIE, which is our transcriptomics. If you have a bunch of blue in section 1, hypometabolism. If there's red in section 2, proliferative physiology and aerobic glycolysis. The cells are doing this on purpose because the construction crew has arrived at the scene of injury, and it needs a very special approach to rebuilding all this. Now, if you push yourself too far physically, you can get what we call that post-exertional malaise. And that is the sense that you can only draw on so much energy. So what's happening is the energy supply of the mitochondria are really downregulated, and we have low reserves. And that's how people feel. We're sort of guppy breathing. We can't walk upstairs without being short of breath. We have lack of motivation and typically depression during the day. But this is all very physical. One of the ways we can measure this is through GDF15 and FGF21. These are very special mitokines that show the person is under stress. In addition to this, and imagine the construction crew is on the scene of destruction, but they're also kind of looking around, staying on guard. And that is to say, waiting for a new fire to start. And by virtue of that, this hyper alertness happens throughout our physiology and even in our mental health. People feel more anxious. We have elevated resting heart rate. We don't sleep well at night. And I know a lot of you feel this way, that there's this background of just, I can't settle down. Well, this hyperalertness is happening all the way down to the mitochondria. It's also why many of you have histaminic reactions. We can see some of that on GENIE with the CCL5 gene and the HDC gene. We can see this with mast cell degranulation. If you are hyperreactive, hyper alert, you're now eating 3 foods, you can't stand a whiff of a perfume, even bright light affects you. You are in this sort of hyper alert state. It means that the mitochondrial reserves are very, very compromised. And they're in that last ditch effort to protect the cell against new threats. It's no different than someone who's been emotionally traumatized in the past that is now hyper alert as an adult. Everything is seen as a threat. The cells are doing the same thing. And it's a teeter-totter. The less reserves, the greater the hyper alertness. And paired with this is this kind of global self-protection mode, where the body tries to conserve reserves because it knows the tank is low. And a lot of you know this in sort of different ways. So for example, when we have overwhelming stress, this is one of the most important self-protection mechanisms. Things go quiet in the body. And that means we lose rhythmicity, we lose our ability to react to stressors, we lose our ability to sort of flow with the daily demands of life. And when we see biology rhythms go flat, that's how we know a person's been traumatized. You know this, for example, is adrenal fatigue, a cortisol curve that's low and flat, but it doesn't end there. We also know this in the CIRS model, low antidiuretic hormone. So when we lose our water balance capacity, we also see this in our reproductive hormones like low testosterone, DHEA. Anything that's supposed to be pulsed during the day or the night, we lose that rhythmicity. And it means the body and the cells are going quiet. And therefore, that hyper alertness and self-protection is sort of wired and tired. We're hyper alert, but we're conserving. And where the construction crew is kind of running on in the background on that low energy. It's a terrible place to be. We're reactive, but we're tired. We want to sleep at night, but we can't, but we don't have the energy during the day. And when we see abnormalities in these levels, like a high TGF-beta1 or hypometabolism on GENIE or excess histamine production or flattened cortisol curves or low ADH, we know we're in that state. Now, the good news is that there are even better markers to tell us specifically where we're at. And this is where the bench science is now moving to the bedside. We saw clues in the CIRS model, but now we can measure with a lot more specificity exactly how compromised the mitochondria are. How low is that reserve? How hyper alert? How sort of decompensated are your mitochondria? Which gives us sort of a new window into what to do to get people better. So we then have to sort of honor the fact that rebuilding needs to occur. And then finally, we move into CDR3, which is it's time to move back in. And this is maybe one of the greatest insights that we've had. And that is to say, it's all clear. It's okay to move back in. And this is what resolution looks like. The inflammation is off, the repairs are complete, the debris is cleared, the daily rhythms are restored. Now, the safety signals, interestingly, that are sort of part of this whole process are ones that to some degree we've identified. VIP, MSH, those are part of the safety signals of the brain, the neuroendocrine network. But that's only one part of the story. It turns out that there are all sorts of other safety signals that the body requires to heal. And one other side of this, among many, is that we need to feel safe. So a measure of that could be heart rate variability, for example. And I have a lot of my patients follow their heart rate variability. It's a measure of stress and trauma in the nervous system. And we talk a lot about how do we move through a history of emotional trauma. I would imagine many of you feel like So you went through sort of a difficult process first, and then you started reacting to your environment, which is true for a lot of us. It's not like we all woke up one day because we have certain HLA and, as children, and it was written in the stars that you were going to react to mold. It's a total load issue. And that means a history of emotional stress on top of other kinds of biological exposures, load the system to the point where it finally explodes into CDR1. When we send the right safety signals, we see VIP coming back online, MSH coming back online, a restoration of heart rate variability, macrophages that are now functioning normally without a lot of inflammation in the system, and the set of other markers have normalized, including our deep mitochondrial markers and even our epigenetics. And so by virtue of that, what we've learned is, interestingly, you can remove the exposure, you can do the core repairs, but until the person gets the right safety signals, CDR3 doesn't return back to normal. That person can remain stuck. That's fascinating to me, that each stage is gated. You can't go from one stage to the next until you satisfy certain criteria. So this, to me, sort of begins to map the treatment sequencing in a way that allows us to fortify how we function in the world. And that means we need to match each intervention to the phase. We never push rebuilding while the fire is still burning. You have to put the fire out, meaning remove the exposure, lower the trigger load, and calm the innate inflammation. You don't rebuild a burning house. In addition to that, once you move to CDR2 and the inflammation levels are lower, you're passing your visual test, MMP9 is resolved, CRP is resolved, we don't see a lot of markers of inflammation, then the CDR2 work begins. The construction crew arrives, but we know we're still in a low mitochondrial state. It's low energy, low reserve, flattening of cell responses, and we need to nourish the individual and support that process so the body can repair, we can improve mitochondrial function and settle that hyperalert state. And then we hand back the keys in CDR3, where we give specific safety signals to say it's okay to heal. It's all safe now. You don't need to be on such high alert. The journey back to health, therefore, is one that is guided by your biology. There's no single road back. Every person's terrain is unique. Your trigger, your reserves, where you sit in the cycle, it's your own. So we need to match what we do with the right therapy at the right moment to move you through this process in a very specific order, and order matters. I can't state that enough. One of the big breakthroughs in the mitochondrial research is that, again, you will not progress from CDR1 to CDR2 to CDR3 if you don't gate correctly. If there's still work to be done in CDR1, you will not transition to CDR2. And so we need to sort of honor what we now have learned about the biology. And I talk a lot about this with my patients of, I'm not a lumper. I now am very disciplined about, we do one thing at a time and then we move on to the next, and then we move on to the next, and then we move on to the next. And we sort of unwind all this, that we need to read the terrain, we sequence the intervention, and we need to personalize each step. No one size fits all ever with this. That's a very limited understanding of how our bodies work, how the mitochondria function. It just doesn't map to what we know about our biology now. And I think a lot of you sort of appreciate this, that, if you kind of march in lockstep and you just did the same thing for everybody, do people heal? And the answer is no, most people don't, or they get stuck at some point. So, we have a whole program now at Beyond Mold. We have decades of experience at your fingertips. So we have Lori available, we have Michelle available, we have a messaging program. Well, for $99 a month, people can ask as many questions as they want about what's going on with their health and what's going on with their home. And my whole team is available to walk people through this journey. I'm doing individual consults in addition to having all of these resources at our disposal to make sure people are moving through the process. It's a whole new world in terms of what we can measure and the order in which we intervene. And that's really the whole purpose of all of this. So I'm going to stop sharing right now. And there's a lot of questions, which I love. I guess I'm going to kind of go back to the top. Cool. So let's see. I guess I'm just going to go down. Should I just go down the list? Should I go down the list? Okay. I'm going to go down the list and we'll see if I can get through a bunch of these questions. We got plenty of time. So is that PACAP peptide available for patients to take yet? Not yet. So what is PACAP? So PACAP is a peptide that is very similar to VIP, but even stronger. Now, this raises an issue, and that is to say, what about VIP? Is VIP really special and unique? Is it our only tool in the toolkit? Well, I know there's a big sort of devoted crowd to VIP. Let's put it in its proper context. What is VIP? Vasoactive intestinal peptide. It's a 28 amino acid sequence, and it's produced primarily in certain areas of the brain, the anterior hypothalamus. There are two different VIP receptors that are scattered throughout tissues and organs in the body. And it has a variety of different functions, but getting beyond the specific biology, it's one of the more important all clear signals. It tells the brain and the body, you're safe. It's okay to heal. And wasn't that brilliant, what Dr. Shoemaker had identified 20 years ago, which is to say, when you get to the end of therapy, if you click all the boxes, the body still needs an all clear signal. I'm not so sure he really fully understood why that choice was so brilliant. But here's the problem with that. Number one, it's not the only signal the body requires. And number two, if it's used inappropriately, the body will not heal if you don't honor that mitochondrial progression. And so who wants to have only sort of one treatment when you sort of get to the end? Well, I certainly don't. We need to put that into a context of what are all the signals that the body requires to heal. Peptides in general are very powerful for sending those final signals. VIP is one among many. And so PACAP is another one. PACAP has been used in a variety of research studies, but it hasn't been used yet in humans for prime time. I think eventually it will be. But be that as it may, it's just sort of a sister to VIP, but something that you should probably be aware of. If brain damage from a TBI can be similar to SIRS, is the treatment similar? The answer has been yes so far. So I have an approved research study right now with Dr. Ross, who I think is kind of a world expert on neuroquant. He really is the world expert on neuroquant, especially with mold exposure. And we are looking at the overlap between traumatic brain injury and mold exposure. Now, why is that unique or important? It's because when you look at standard neurodegenerative diseases like Alzheimer's and Parkinson's, there's a uniformity in the idea that it's different areas of the brain that tend to shrink over time. The hippocampus for Alzheimer's, the basal ganglia for Parkinson's, certain areas for other kinds of dementing disorders. But the idea is that the brain is shrinking. What's interesting about traumatic brain injury is that it's sort of characterized by the idea that certain areas swell and other areas shrink. That was novel and new, all on its own, in terms of something that was chronic, but had a very different sort of fingerprint or signature on the tissue of the brain. It turns out that when you expose the brain to mold, the same sort of thing happens. There are areas that swell and other areas that shrink. And by virtue of that, they're sort of kissing cousins. Now, are the patterns the same? No, they're not. It turns out that there's even more swelling in exposure to water damaged buildings than there is to traumatic brain injury. Traumatic brain injury has more shrinking, or what we call atrophy. Now, do we treat them the same? By and large, yes, because the pattern is very similar. With that being said, you can't successfully treat the brain until you sort of move through these phases. You have to make sure that a person is really ready to heal. essentially. And that's true for traumatic brain injury. If you think about it, remember, physical trauma and stress to the tissue can turn on the cell danger response. So yes, you get vector forces across the brain because of the original injury, but you can perpetuate chronic TBI by turning on the CDR. And so, the CDR is not a total model to explain sort of how everybody gets sick for everything, but it's very important to understand this is what keeps people sick in that sort of chronicity. The treatments then are very similar in terms of, yes, we take a CDR approach in that regard to both categories. But it also means that when you look at our toolkit, we have lots of other choices now, well beyond, quote, VIP, to help restore normal brain function and tissue. And, there's a variety of choices now that I think are pretty extraordinary. So, for example, nicotinamide riboside, which turns into NAD. A lot of you are probably familiar with that. Lion's mane. One of my favorites is something called RG3, which is a derivative of Chinese ginseng. It's a ginsenoside, which has been shown to have incredibly neuroprotective benefits. And so we use that all the time in my practice because the brain takes a big hit with these exposures. And I try and do as much as I can to protect the brain along the way. So the answer is yes, we sort of take a very similar approach between the two because the damage signature is very similar as well. And both can end the person up in CDR. And don't forget, one priming event can lead to others. I cannot tell you how many times I've seen a patient who had, let's say, TBI, and then they started to respond to mold, or they had a car accident and then responded to mold, or they had emotional trauma and then responded to mold. You cannot underestimate how these things stack over time. How do GLP peptides send safety signals? Do they continue to be effective at this in small doses, even when the tolerance goes up and appetite? Yeah. So aside from GLP's effects in the body relative to appetite suppression, where do they work? If you go back to what I was saying before, that you have a danger signal, it then goes through the integrated stress response and then down into the mitochondria. It turns out, and this is fascinating, that GLP-1s offload that integrated stress response. They actually improve what's called GAD34. It's an enzyme that then dephosphorylates the EIF2A. It means we can turn off that integrated stress response. Why is that important? Because the cell basically can be running on a false positive if the integrated stress response remains intact. Think about that. We remove the mold. You get rid of the chemicals. You fix your diet. You manage your stress. But if that integrated stress response remains active and EIF remains phosphorylated, guess what? It's going to keep sending signals down to the cell danger response that we need to stay in battleship mode. What does that mean? It means you get false positive labs. You get a false positive GENIE. You get kind of what I call false positive symptoms, that your body and cells actually think the threat is still around, that you're still in CDR1 when you're not. How many times have I seen people do a GENIE, for example, and the systems, the genes that we look at to see whether or not the cell is still in distress are still active. And the ones in particular that relate to mold are still turned on, but we've already had our team go in and fully remediate a home, and we know that it's clean. We're like, wait a minute, why is GENIE still telling us that it looks like this person is still in exposure when we know they're not? Why? In the integrated stress response, we can look at mitokines, we can look at mitochondrial function, and then now we have new tricks like GLP-1 and others that can offload that integrated stress response. The false positives and the rabbit holes of data that are available to us are enormous in this category. If you look at our full data sets, the visual test is non-specific. It's not just mold. The labs are non-specific. They become abnormal for all sorts of things. You can get false positives on GENIE, for example. There is all sorts of ways to sort of fake yourself out when it comes to this topic. So you need to be really data-driven and understand what you think the data is telling you paired to what the person's symptoms are. And so dealing with that integrated stress response is really important, that we completely overlooked in this category. If GLP-1 meds slow gut motility, what do you think that does with the microbiome and endotoxins? Well, I would say slow down. Number one, remember order matters. So I wouldn't do GLP-1s in the very beginning. We need to improve gut function. We need to gain control metabolism. We need to move people through CDR1 and CDR2. Then we might look at mitokines and mitochondrial stress factors and decide whether or not the person needs GLP-1s. It's at that point where the GLP-1s really shine. And it often helps unlock people to get into CDR3. I use it as sort of a transition treatment between CDR2 and CDR3. Here's a good question. I'm an 11.352B. Can I ever get better? I'm truly not getting there. And so beautifully fighting. So this gets into something, I'm going to probably ruffle a few feathers here, but let's just talk science for a second. You're mentioning something called HLA, and I'm assuming most of you know what HLA is. Human leukocyte antigen. Now, these are gene sequences on chromosome 6, and they were meant to be part of a normal immune response. And there's sort of this mythic idea that has been around from really the very beginning of the CIRS model that HLA is what sort of predicts vulnerability. And there are essentially 9 gene sequences that have been identified that form the core of what we think is this inherited disability or vulnerability. And that is to say my HLA. And if I have certain HLA sequences, they're thought to confer different kinds of vulnerability. So I'm a 15.6, which is supposed to be a Lyme vulnerability. Beautifully fighting is an 11.352B, which is considered multi-susceptible. There's the 4.353, which is the dreaded. There's 1.5, which is low MSH. Now, where did all this come from? Well, it came from a single presentation from Dr. Shoemaker in 2002. He presented a poster, and he said, there must be a reason why some people are vulnerable to this illness. Here's the problem with this. It's never been validated in the research. And those gene sequences in particular have never been repeated in any sort of formal way. And here's where it gets really sticky. When you look at any further research on HLA, the conclusion is the opposite of the original CIRS assertion. Now, what do I mean by that? There are 3 disease categories that have been looked at with HLA. Post-Lyme syndrome, beryllium toxicity, and a sort of a pulmonary bronchitis disorder. And when people have certain HLA present, we see a perpetuation of disease processes, a perpetuation of post-Lyme, a perpetuation of beryllium toxicity, a perpetuation of pulmonary problems. But here's the issue. Those HLA, specifically, all 3 of them show the same thing, that they perpetuate an autoimmune process. All 3. That when you have HLA defects, they basically dysregulate a part of the immune system that triggers autoimmunity. That is the exact opposite of the asserted CIRS model. The asserted CIRS model of the HLA says, oh no, if you have HLA, any one of these sequences, it means that your body remains inflamed and you can't transition to the side of the immune system that would create autoimmunity. But all the data says the opposite. Every single research study that I could find says exactly the opposite. In addition to that, we hear this number that about 22% of the population is vulnerable because of these HLA. If you parse all those different HLAs, some of them are represented in 90% of the population. Others are less than 10%. So the 22% number has been perpetuated, and I can't find any validation in the research either for that. Now, what about this issue, though, of vulnerability? Is that true? The answer is yes. Can you get stuck? Absolutely. Are people more vulnerable to these things? Absolutely. Is it because of our genetics and HLA? I'm less and less convinced. I'm more and more convinced that it's life happening. People with larger total loads and exposures and stress at every level are clearly more vulnerable, number one. Number two, there's a whole body of research, and it's fascinating. If you're ever sort of up in the middle of the night, just Google molecular echo or molecular scarring. And this is the cell getting trapped in the sort of perpetual recording that it's under threat and I remain stuck. And there's also, and I won't go into the biology, but there's all sorts of mechanisms by which echoing and scarring occur, and the ways in which cells get stuck, and the ways in which we become vulnerable, and how we never seem to get out of this mess. But again, we couldn't get there until we did very advanced metabolomics research, mitochondrial stress research. These are all recent ideas. The HLA is 20 years old, and the science kind of moved on. Now, I understand the value of saying, this is why I'm vulnerable because I have the HLA. Maybe. But just understand there's all sorts of other reasons why you might have vulnerability that are probably better explanations at this point. It's a fascinating subject. It's incredibly important. It acknowledges why people are vulnerable and stuck. But to hang our hat on just HLA alone, I think really narrows our focus in a way that sort of isn't consistent with the current science anymore. So what does that mean? Does it mean that you're permanently stuck? No. There's always this opportunity then, because of the functional aspects of the mitochondria, that we can unlock the cycles and have you return to normal. They want to go to normal. The question now is, how do we sequence measurements and treatments to move you through the process so that we remove molecular echoing and molecular scarring? Remember, just as part of that idea is that activated integrated stress response, that if you can turn that off and stop sending the danger signal to the cell, that's part of the molecular echoing sequence. It's one of a bunch. But now that we know that it exists, we can use treatments to target things in ways we never could before. So what's best anyway to resolve fusarium exposure? Well, that's usually more food related. So there's certain foods that are vulnerable to that. And I know that there's sort of this seep and moldy hay. There is this idea that there are certain, quote, binders that go with different mycotoxins. And if we just sort of knew what mycotoxins you had in your urine, we'd know which binders to choose. That science is very immature, both in terms of urine testing for mycotoxins, but also the selection of binders. What I would say, and this isn't necessarily meant to discredit it completely, is that there are no human studies to basically map binders to mycotoxins. It doesn't mean it's a bad idea. It's just a very immature one. And for anyone to say they know which binder goes with which mycotoxin based on your urine testing, I don't know how they would know that, because it's actually a very difficult process to unwind from a scientific perspective. And I'm not saying, again, it's wrong, but I would say be careful when it comes to things like that. Do you need more than, I'm assuming, over-the-counter meds for MARCoNS? I've been trying for 3 years and still have large amounts. So, man, this gets into another area. I've taken a deep dive into MARCoNS. I've not found a ton of research on MARCoNS. And the research that I found is very conflicting. But here's what I think might be happening. We've sort of like HLA, there's sort of these mythic anchors of CIRS, and MARCoNS is one of them. But if you really look at the research on MARCoNS, is it a type of bacteria that releases toxins into the body? There's not a lot of evidence for that. But here's where the story gets really interesting. When we have these exposures, one of the consequences of CDR1 is dysbiosis, which is an abnormal mixture of microbes that begin to appear in different body compartments. Now, we usually think of dysbiosis as occurring in the gut, but we have microbes in mass living inside all sorts of body compartments: the lungs, the upper respiratory tract, the vascular system. Basically, we are not sterile. And it turns out that it's not just inside the body that develops the dysbiosis, but there's an emerging model that our living spaces develop a dysbiosis. And that's why we get sick. There's even systems that emit probiotics into our living space that help displace and correct the dysbiosis in our living space, in the same way that when we take a probiotic, it helps to readjust the microbiome in the gut. Now, here's the posit. And if you look at the research, it's actually pretty strong. All you need to do is ask the question, is there a dysbiosis that can appear in my nasal passages? And can that have a meaningful impact on my health overall? And the answer is yes. And I think one of the things that we ended up doing with chasing MARCoNS is sort of chasing the idea of a dysbiosis in the nose, and that maybe the treatments were sort of affecting more than just whether or not MARCoNS was present. And this idea that MARCoNS releases a polycyclic ether that then creates these systemic changes and affects what we call the mitoribosomes at the level of GENIE, and that, you know, by virtue of that, if we don't deal with MARCoNS, VIP won't be effective. I think there's some overstatement there, but I do think that this idea of dysbiosis in the nose affecting our chemistry overall, that it's sort of an internal source of inflammation, is probably true. I've seen patients where they do have fungal overgrowth in their nose. That matters. That they have other bacterial overgrowth in their nose. That matters. And when you look at, for example, BEG spray, it's very broad spectrum. If you think that's only treating MARCoNS, you're kidding yourself. It's treating all sorts of things in the nose. And I certainly have patients who feel better when they sort of clean out their nasal passages and reduce that sort of dysbiotic burden. So, you know, this notion of, do you need more than over the counters for MARCoNS? I think the question is, do we need to treat the nose? I think so. And with what? Now, the traditional is BEG, Bactroban, EDTA, and gentamicin. Some people have issues with that. And in the early days, if you were looking at MARCoNS in particular, BEG were great. But then we started to see resistance patterns. So Dr. Shoemaker and I had long discussions about, well, what are we going to do? BEG is not working. So we came up with EDTA and silver, or just EDTA. And then there were all these over-the-counter products that were starting to show some benefit as well. Some work better than others, but sometimes you do need to reach for the prescription pad. The single best item, though, for biofilm is the EDTA, and that goes back to Eva Sappi's work out of University of Connecticut. So the EDTA is really important for getting rid of biofilm in the nose. There's nothing better than that. You can do EDTA alone, and over time, we see some restoration of the normal microbiome of the nose. This is such an important subject. We get fixated on MARCoNS, and I would challenge you, go look at the research. I haven't found a lot on that, but I do think treating the nose is probably a good thing to do. What are your thoughts on using a peptide like melanotan-1 for increasing MSH? Are there other things that can also increase MSH? Melanotan-1, the problem with melanotan-1 is that it'll bronze the skin and it can cause nausea and other things. I find KPV is a much better choice, which is a derivative of MSH. And so KPV is something that we can take orally, and it helps to seal up the tight junctions in the gut. It also raises MSH. It's one of the stronger safety signals, like VIP. And when you pair KPV with VIP, you get a really nice complement. In addition to that, there are other safety signals while I'm on it. Oxytocin is a lovely safety signal. Low-dose naltrexone is a lovely safety signal. There's all sorts of ways of sending those biological inputs for safety signals, and sometimes we have to do them in combination. I'm not a huge fan of melanotan, but I do like KPV. How do you feel about therapeutic plasma exchange? I think if you do plasma exchange towards the end of treatment, you really potentially could benefit as you're kind of cleaning out sort of the tail end of CDR2, that you're getting rid of debris, you're doing autophagy, you're turning over the cell's ability to repair and heal much more quickly. And so done too early when the fire's still burning in the house, it makes no sense. Done later in the process, you could even argue it's a CDR3 with respect to helping the body heal. Have you had success in getting rid of stubborn MARCoNS by using hydrogen, that must be peroxide, and saline nasal rinses? So, yeah, I mean, again, you know, getting back to the issue of why are we chasing MARCoNS and do we have to get rid of it? one of the things I didn't mention before, but I think it's important, we tend to get fixated on the idea you've got to get rid of MARCoNS before you do anything else, before you can do VIP. What we've learned is people heal and the body goes back to normal, even if you're in CDR3 and you have active MARCoNS. One of the things, if you're worried about MARCoNS, you just have to actively treat it and suppress it so that it allows the body to heal. Even then, I'm not totally convinced, but I do sort of follow the theory in that regard. So if a person has active MARCoNS, we do treat it, but I don't let that stop us from moving forward. I don't let that stop me if I'm now arriving at CDR3 and I haven't gotten rid of MARCoNS. You can actively treat and suppress MARCoNS, and the safety signals will allow the body to go back to normal. So you don't need to get so fixated on, oh my gosh, I haven't gotten rid of my MARCoNS. In terms of specific treatments, unfortunately, it's become the Wild West when it comes to, quote, getting rid of MARCoNS. Some people get rid of it quickly with your standard BEG. Others need the slow train with like Xclear and other things. Any one of them is sort of fair game. I've seen people clear with a variety. And we have a whole list of treatment choices on our website of Beyond Mold, both over-the-counter and prescription. We find that potentially EDTA plus silver is a really nice choice for a lot of people. But it takes time to get rid of this stuff if you want to sort of really focus on the MARCoNS idea and say, I got to get rid of it. But again, give yourself a little breathing room. If you're otherwise making progress, you're out of exposure, you're going down the treatment path, you're getting better, and you're arriving at that final step, and you say, okay, I'm on VIP, but I still got MARCoNS. It's okay. Just keep treating your MARCoNS. You can do your VIP and the rest to do sort of finishing school. Do you believe that you really have to avoid mold the rest of your life once you've unlocked CIRS? So here's the thing, and this is the model that's sort of, I think, the most contemporary out of all this. Think of it as sort of a numerator and a denominator. In the numerator, it's total load. And that is to say, all the things that you sort of accumulated over your life that's loading your system. Now imagine in the denominator, it's your reserve, it's your resiliency, it's your robustness, it's your deep capacity to absorb those insults and stressors and exposures and come back to normal. Some people have a deep well and a lot of resiliency and reserve. And others, they have a very tiny reserve and they get overwhelmed by small loads. So here's one of the things that also happens in reverse when we sort of take people through the treatment process. It's not just about removing the total load. Number one, that alone won't get people better. It's not even about just sending the safety signal. We also then need to ask questions about how do we fortify a patient? How do we rebuild their reserves? And I think that's where some of the longevity practices start to shine a little bit more. Cold therapy, hot therapy, intermittent fasting, caloric restriction, graded exercise. These are the sorts of things that start to unlock the cell's potential to build longevity. Once we get to that point where we're sending the all clear signals, that's when I start thinking about how do I build the person back up? The model you should have in your head is as an athlete. Imagine we started with someone who's very deconditioned and sickly and in bed. Now we finally have the person out of bed and moving around and feeling pretty good. But then how do we transition them to become a competitive athlete? We need to build their system. We build their system through very specific interventions. And that's where I think these longevity practices start to shine. I don't think caloric restriction and graded exercise and all that sort of stuff makes a bit of difference if you're in CDR1 or even CDR2. But once you're in CDR3 and beyond and you're sort of back to normal, that's when I would say start building your tank. Start building your reserves. I put people in walking programs. I want them to be with a active heartbeat of 120 to 130 beats per minute. I want them to do that for 30 to 45 minutes, at least several days a week. Why? Because all the literature says that when you're in that stage 2 of activity, where you're you're working, but you're not working too hard, something magical happens with your immune system. It starts to reset. You get autophagy. You start to burn fat. Energy levels go up. You're not spilling over into cardiovascular exertion. There's a sweet spot for people. On top of doing heart rate variability training, autonomic nerve stimulation, insight therapy, cold and hot, sorts of exposures. These are the things that start to rebuild people back up. And so I don't think this is just, oh gosh, I can get you out of mold and feeling a little bit better, but you still got to live in a bubble for the rest of your life. We are not designed to be that way. Our bodies and our lives were meant to be robust, resilient, that we can take exposures and not just fall apart. And that's the emerging model, that we can start filling the tank again. We have to sort of take all these pieces that we're learning from different parts of medicine and put together a better model. But it also matters in terms of when you do these interventions. What causes chemical sensitivity? So chemical sensitivities would in some ways would be no different, that, some people are primed. And if you saw my last talk, there are basically 5 danger pathways that are sort of the sensing systems to know whether or not there's a threat. That then these 5 pathways go down to the integrated stress response, that then goes down to the mitochondria. Now, are those the only ways that chemicals sort of trigger illness in the body? No, that was restricted to the model of the CDR. Chemicals will interfere with enzyme systems and substrates directly. They bind to lipid membranes and tissues and cause all sorts of direct injury in the same way mycotoxins do. The mitochondria can sense mycotoxins that are around, but the mycotoxins are also doing direct damage to the body. So can you get sort of these other kinds of responses where we lose our detox capacity and glutathione pools drop, in addition to triggering, let's say, autoimmune conditions? Absolutely. So, what I've done is sort of restrict our modeling to just the CDR, but chemical sensitivities come in all sorts of shapes and sizes. One is triggering the CDR, but they can have direct effects on the tissues as well. One of the most famous and common is how it induces insulin resistance. And that is actually an effect on the beta cells in the pancreas. There's all sorts of studies looking at pesticide applicators, for example, who have a 8 times risk of developing diabetes in the next 10 years, because these are chemicals that tend to disrupt the endocrine system. Okay. I would love to reduce my issues with histamine, mast cells, chemical sensitivities. How do you feel about KPV? How safe a peptide is this in your opinion? I'm eager to try, but the money, yes. So a few things. I don't find that KPV is what restores or sends the, it's an all clear signal because it raises MSH. But remember, where in the CDR is the hyper alertness? It's not CDR3 where KPV really shines. It's CDR2. So instead, you should be asking the question, how do I build my mitochondrial reserves? How do I reduce proton leak? How do I improve cell membrane integrity? How do I build respiratory capacity of the mitochondria? How do I improve immune status, especially adaptive immune status? There's all sorts of other questions we need to ask to encourage the CDR2 rebuilding process to lift the mitochondria out of that alert state. Yes, you can do antihistamines and the chromalins and quercetins, but even the mast cell devotees will tell you the same thing. All that does is sort of mask the symptoms. It doesn't lift the person out of that illness. And so we really need to get good at CDR2 to get someone out of this hyperreaction mode. Because remember, the construction crew is on the scene. They're in that alternative energy supply. They're hyper alert, and the system has gone quiet. And when you say, gosh, I've got histamine, mast cells, chemical sensitivities, that sounds like CDR2 to me. So that's where you should be focusing. How do you treat a concussion when you currently have SIRS? What's the best size healing for brain besides, there's so many. Unfortunately, the FDA in their infinite wisdom has done a lot to sort of restrict our access to peptides in general. The ones that I love without sort of acknowledging, is it on the go, no-go list. And actually, there's a big discussion at the end of July about which peptides are going to be available. BPC 157 is a big one. Dihexa, C-Link, C-Max, cerebrolysin. My goodness, if we could all get our hands on cerebrolysin, we would be a much different crowd because it's so good for brain healing. In the absence of those, I suggest like RG3, which is the ginseng extract, which is excellent for the brain. Other adaptogens like salidrosides, high extract salidrosides are really good for the brain. Lion's mane has been shown to be good for the brain. There's a variety of these that are out there. I wish we had direct access to these peptides. VIP is just one among many. And so what does VIP do? It basically helps deliver, blood and oxygen to the brain, but it doesn't have the healing properties that BPC 157, cerebrolysin, dihexa have directly. And I've seen this because I've had patients who are in comas that I've been able to wake up with BPC 157 and RG3 and other things. So that, I've been on the front line when people have these brain injuries. And, yes, VIP has a role to play, but I don't think it's nearly as strong as some of these other treatments that are now available to us. After the food panel, as you test foods in yellow columns, if there's no reaction after giving them up for 3 weeks and then trying them, does that mean you can safely eat that food? Yeah. So if you have a food panel and you've eliminated foods for at least, I would say 6 weeks, and then you reintroduce them, 3 weeks is minimum, and you don't feel like you have a strong result or reaction, I think they're okay, especially if they're kind of in that moderate panel. I'm glad we have a GENIE question. My GENIE showed I'm reacting to endotoxins, not mycotoxin, and it seems few understand how to address. I've got MCAS and POTS and estrogen dominance. It seems fasting and limited diet are critical in my case. So Dana, a few things. While GENIE in many ways is non-specific, and understand what GENIE is. GENIE is transcriptomics, and what it's really saying is basically we're measuring what is the instruction set that we're sending to the cells. That's what GENIE shows. Doesn't mean we're measuring what the cells are doing. We're just measuring the instruction set. These are genes of the mitochondria. So it turns out then what I really want to know is what are the mitochondria actually doing? It's nice knowing the instruction set, but I want to know the end result. In GENIE's case, though, the toll-like receptors that turn on to endotoxins are actually pretty specific. So toll-like receptor 2, toll-like receptor 4, that's in section 10 of GENIE. Now, here's the conundrum. What are endotoxins? Endotoxins actually come from what are called gram-negative bacteria. Where do gram-negative bacteria live? Mostly in our digestive tract. So animals and mammals and us, we're very good at producing endotoxins. Endo meaning inside. That's where we got its name. It's a type of what we call lipopolysaccharide. Now, if you live with cats and dogs and capybaras and whatever, and they're not always clean as they should be, you can have endotoxins begin to build up in your living space. It's a very common way we get endotoxins. The other is if there's a sewage leak or a sump pump that's not sealed or a septic tank that's having an issue. That's also how we get exposure to endotoxins in our living space. Or if you live on a farm and there's just a lot of poop around, you're going to get endotoxin expression. Now, here's the thing that gets overlooked in the CIRS model. When we see a GENIE that says, oh, endotoxins, well, guess what? It could be your gut that's producing these endotoxins too. The gut is very good at not only producing endotoxins, but liberating them throughout the vascular system. So if you're a little kind of confused about endotoxins, look to your gut, get your gut right, and then I would suggest doing small particle cleaning. So I would say, small particle cleaning is really the key for how we deal with endotoxins. And good air filter systems. We at Beyond Mold, we're big believers in sealed vacuum cleaners, specific microfiber cloths, branch basics, good air filters. All of these things matter in terms of knocking down the endotoxin load. Let's see. I know that Shoemaker recently discussed introducing VIP sooner than originally discussed. What are your thoughts on that, and what determines readiness to start? So a lot of that has to do with hypersensitivity. VIP is very good in low doses if a person's hyperreactive, and it helps to settle the cells down in terms of their reaction. And we'll do very low dose VIP in that regard. But if you follow the biology and sort of this idea of readiness to heal, you won't get the big benefits of VIP until the body is truly and finally ready. Let's see. It looks like there was a point, I'm sorry that you couldn't hear, but it looks like we're back. Let's see. What do we even call this illness if SIRS doesn't get us better with Shoemaker Protocol? Is it CDR as the more encompassing label? I think, and I'm biased, and obviously I've been fully devoted to SIRS for a long time. But again, I think SIRS is the country, and I think the cell danger response is the continent. That when you look at the totality of how the cell danger response and its elegant mitochondrial metabolomics and all of its glory and all of its nuance, it not only got to the answers faster than SIRS did, but it's much broader and more complete. And I think a lot of us have sort of naturally lived that experience where we say it can't just be mold and it can't just be well-calling VIP. There's got to be way more to this than just that idea. That's just too narrow. And so the cell danger response sort of opens us up to acknowledging there's all sorts of other exposures that get us into this state of affairs. There's all sorts of other measurements that are now available to us to better understand where we're at. The idea of gating and progression, that we move through these phases in an orderly process, really hit home for me. And this idea of safety signals and building robustness also too. And that it's easy to sort of get so fixated on the biological and the physical that we've ignored half of the equation, which is the emotional and mental terrain that we also need to deal with. I think that that is as potent and as powerful, that as we contact the autonomic nervous system, we balance the parasympathetic and sympathetic, we deal with the history of whatever issues are still carrying us forward in terms of trauma, if they're present, we do the deep work and the hard work to get us out of that trauma state. The cells don't make a distinction. Whether it happened in childhood or as a big mold exposure or traumatic brain injury or whatever it is, the work has to be done. And one of the things that I think of is that there's a lesson here with respect to, we see this as a trauma-based illness. Okay. Audio's fine. Okay, good. If you have reactivated EBV, at what point in the protocol should antivirals be introduced? I introduced them during CDR1, which is, we got it. To me, that's an exposure issue. So I'll do antivirals on top of dealing with mold and the rest. We have to deal with that right away. Let's see. Why don't we do KBV early? That is magic. Well, again, sometimes it's all about when the signal occurs. Thoughts on chronic migraines. So yeah, that's usually histamine release around the outside of the brain. I tried microdosing tirzepatide twice, but was still in mold and not aware and flared up terribly. Yeah. I don't do the GLP-1s until we reduce the exposure. We're beyond CDR2. Then we want to offload the integrated stress response pathway. So I don't do those too early. I don't think you get a big effect. And sort of like what you had, it potentially can flare you. Do you need a nasopharyngeal swab for MARCoNS testing, or is the NARS test good? I mean, it's a deep nasal swab. That's what you're supposed to do. If you've been on low-dose naltrexone from the beginning and are still working on getting better, is it still sending a safety? It is. It absolutely is. And for some people, it can help stabilize their emotional state while we're moving through the process. I like LDN quite a bit. It helps to adjust the inflammation in the brain, which helps to balance inflammation throughout the rest of the system. So LDN is one of these things where you can use it in different phases of the journey. For a patient with persistent fatigue and headaches and head pressure, autonomic symptoms, uveitis, rising ANA, elevated MMP9 after 2 years of VIP, how would your treatment strategy change? Well, I would go back to the beginning. I mean, this sounds like if you've got an elevated ANA and MMP9, you've got exposure going on. And so you're CDR1 until proven otherwise. So I would really focus on what are all the exposures that we need to deal with. Let's map those out. Let's make sure we eliminate them. I want to see your MMP9 falling. I want to see your ANA falling. I want to see you passing your visual test. I want to see you out of exposure and, showing that we can sort of correct those signals first. And then I would move you on. Let's see. How do you know where you are in the CDR triplex? Okay, so thank goodness there are new tests available that we're doing, and and it's really a mixture of tests. There are inflammatory markers. There's deep mitochondria assessment tools now available to us. There's mitokines. There are kind of other related signal measures for healing. I always want to make sure my patients are following heart rate variability, if nothing else, to measure the stress in their nervous system. You have to kind of map all of it and be able to target where we think the person is stuck. And then we go in and we sort of undo it. If the person's inflamed, but they have low mitochondrial reserve, you deal with the inflammation first because they're still CDR1. If the inflammation levels are low and the mitochondrial reserve is low, then they're CDR2. If they're not inflamed and their mitochondrial reserve is good, but they have low MSH and low VIP and low heart rate variability, they're CDR3. So there's a way to sort of map all of this depending on sort of, where the person is at. And you always go to the earliest phase first. So if CDR1 is present, you got to deal with that. If CDR1 and 2 is present, it's still CDR1. If it's 2 and 3, it's CDR2. You got to go to the earliest phase where the person is showing stuckness. TBI, is this something she should be on? Yeah, so that's synapsin. So synapsin is RG3. And so that would be 1 to 2 chewables per day. So it's yeah, Lori, there you go. Is there a right timing for dealing with emotional trauma? Can it be done too early? I don't think it can be done too early. I think it's something that could be done all along the way. And there are different ways of dealing with it. So, for example, I might recommend EMDR. There's a home device called Biotoxin, which is really good at replicating EMDR. There's another device called Truvaga, for example, or Sono, which is great to help stimulate the autonomic nervous system either through the neck or the ear. There's general heart rate variability and coherence training through HeartMath, in addition to the contemplative and insight-based practices and programs like DNRS and Gupta and primal training, any and all of those and more. It looks like we're going to be going into a partnership with a network of psychiatrists and therapists to help people move through emotional trauma as well. Does hypometabolism cause you to feel like you have low blood sugar without actually having? Absolutely, it does. And it's because, the cells are burning energy, but inefficiently. And it's the feeling state is like an empty tank, essentially. So yes, absolutely. I specialize in HTMA and see a big correlation between suppressed minerals in the cells and mold. Have you looked into this in terms of research as a tool? It's very insightful and explains a lot. So Yes. In fact, if you look at the mitochondrial metabolomics, what happens is, remember when the cells go quiet, it's one of the defense mechanisms by which we know there's been an overwhelming trauma and stress to the system. So, and not to go into it in any great detail, but we know the mitochondria actually direct minerals and nutrients to be sequestered and reserved. And you'll see apparent low levels when you measure them, because the body has gone into that protection mode. Flattened cortisol curves, low testosterone, low mineral reserves, holding on to toxins. We lose our ability to detoxify, all as part of this. So the answer is yes. We've already sort of mapped a lot of that out in terms of the ways in which nutrient pools are shifted and sequestered and changed as a result of the mitochondrial stress response. Thoughts on psychedelics? I've talked to 3 people who healed using ibogaine. I've had lots of discussions about ibogaine and sort of, deep insight work and the stuff at Johns Hopkins and psilocybin and the rest. This is a trauma-based illness. We're all traumatized by this thing. We all live in a little bubble. We don't feel well. We don't want to leave our homes, but our homes are typically making us sick. We can't tolerate stress. Our relationships are falling apart. Our bodies are falling apart. We've lost our meaning and purpose. I mean, I can't think of a more traumatizing illness than this one, honestly. One that's not necessarily life-threatening. And so by virtue of that, anything we can do to offload that sense of trauma is good with me. And so I think the insight work that people are doing and to sort of correct those deep mechanisms have a big role to play. And I think it's a really kind of unexplored territory. Has your opinion on ivermectin changed over the past few years? And if so, what evidence changed your thinking? I don't think it's really changed all that much. I mean, I think, we're learning more. I don't know if this relates to long COVID in terms of we know that the gut can have, let's say, COVID reserves. So there's sort of persister infections with COVID, that it's not just a persistent immune response. So I think, ivermectin might play an important role. I think it's one of these things where, there were all these camps around ivermectin and it showed a lot of promise, but I don't think we understood what to measure first to know whether or not we should do ivermectin. It was sort of the scattershot approach. My guess is the better measurements that we get, the more ivermectin it rises on the list of what can be done. But I do think it's more about using it in a smart way. Primal Trust. So Primal Trust is one of these programs that helps people deal with emotional trauma and build emotional confidence. For patients with Lyme and other vector-borne, what's the order of steps under CDR? So it's an exposure. So Lyme is CDR1. And I find, and I know that there's different camps that are out there, if you've got Lyme and mold, I deal with Lyme first. I deal with that bug load. We do antibiotics, antimicrobials, herbals that are antimicrobials, and we deal with that first. And we kind of knock down the bug load, and then we start dealing with the home and binders and all that sort of stuff. I find that that's, for me, has been the best way of dealing with the co-problem of Lyme and mold. I know there are other people saying, oh, no, you got to do mold first and then do Lyme. I haven't had as much success doing it that way, but it's CDR1. LL37 is a peptide for bacterial dysbiosis. I've absolutely seen LL37 be helpful for dysbiosis and as an amazing antimicrobial. But again, in the FDA's infinite wisdom, LL37 is something that right now is sort of beyond reach. But again, I love peptides. So if in Beyond Mold treatment, do you offer service for mitochondrial rebuilding and repair? Absolutely. So we now have access to some of the most sophisticated mitochondrial testing you can do. Again, it was all bench science until recently. And now I have access to sort of the deepest measures of what the mitochondria are actually doing. It's fascinating. And it's so important. I'm also able to pair that with soon 5,100 epigenetic markers, meaning what's happening around the genome. We will now begin to build a much better map of where is the person at, meaning what are the signals going down to the genes and what are the signals coming out to the mitochondria. When we can map this with real clarity, that's when we start to see these big breakthroughs. I can measure the mitochondria in ways that I couldn't even a couple years ago. And now with epigenetics and multi-omics platforms, we're getting much closer to sort of that brilliant idea of precision medicine. And I think it's a new day is here. It's why I'm sort of breaking apart the sort of nomenclature of CIRS, because that fits in a much bigger model. And my hope is even today with the slides, you could see sort of where the CIRS ideas fit or don't fit. What do you say to doctors who feel mold is an allergy response and CIRS is not validated? Well, what I typically say is, if nothing else, go to NIH. And on the mold webpage for NIH, it specifically says that we frame shifted away from seeing mold as purely instigating allergic responses. And now there's a whole category that we recognize of inflammatory responses. That's the half step that I take a normal practitioner through to say, we now know there's more going on in the body than just IgE-mediated allergic responses. And here's some of the evidence to show that the model has grown in the past 10 years, that there's more of an inflammatory process occurring. This is much more damaging to tissues and organs. This affects the mind as much as the body. And there's a whole, sort of body of research now to validate that. So that's what I say. And I say, go to NIH. Don't listen to me. Go to NIH. Okay. Let's see. Amen to that. Yep. How do you treat CIRS as well as Lyme, Bartonella, trigeminal neuralgia, and occipital neuralgia? I've been in chronic pain for 3 years straight. This debilitating burning pain is all over. That's a tough one. There are a number of reasons why we see chronic pain syndromes as part of the CDR. There are alterations in certain areas of the brain. There's excoriation and injury because of the inflammation to peripheral nerves and the autonomic nervous system. It really kind of depends on what your particular situation is. When I see the list of, I have Lyme, I've got Bartonella, I've got mold, I've got viruses, what I do is I go back to the drawing board and I say, and not to be combative, but to say, what do you really have? Are these positives or false positives? What exposures are really here? And what exposures does your body think are still here? And so, we have to be very clever in terms of getting data, but also knowing when to trust that data. One of the failures of functional medicine in general is there's all sorts of tests that are out there and patients are told they have all sorts of problems, but not all tests are the same. Not all tests are reliable, and there can be a lot of false positives and false negatives. No testing is perfect. And so if you're not making progress with your particular disease complex, you need to ask at least 2 questions. Do I have the right diagnosis or do I have the right treatment? Many people think it's a failure of treatment. I'm a bit biased. I usually think it's a failure of diagnosis. And so when someone's really complicated and really, as sick as you are in terms of, I have these labels and I'm in chronic pain and I'm not making progress in 3 years, we go back to the drawing board and let's break it down and let's really ask the question, what do we know and what do we don't know? So let's see. You got me to VIP in 24. Current CIRS doc says I have Bartonella, treated with herbs, but second plateau for 2 years. Can I book with you to determine Bartonella or CDR? Sure. You're just going to be on mold. You can get on my schedule. No problem. Thoughts on stomach swelling and then feeling like I can't breathe at times. Stomach is hard. Yeah, that's a histamine reaction. That's and maybe SIBO. So I would check for both. Tested positive for CIRS. Just started treatment for SIBO today. Should I wait until SIBO is treated before I test them on it? Yeah, I would. That to me, that's a bit more of almost like a CDR1 because it's bacteria in the wrong part of the digestive tract. And so I would kind of deal with the SIBO first. And then I would sort of, let's look at the mitochondria and see what we have left. If we kind of got you through a number of phases. Hyperbaric chamber, red light therapy. Yeah, I mean, certainly hyperbaric for pain, I think is reasonable. Who's the top provider that you recommend these days to work with children who does telehealth as an option? It depends on the age. So for me, I'm a family doc. I'll go down to 7 or 8 years old. But, under that, I don't know of anyone that is really actively treating this complex, unfortunately. I'm the one with endotoxins. I'm a veterinarian and life on a farm. Well, there you go. Can I heal with my job and location? Probably. I've done massive cleaning, but if I eat multiple meals a day, I go backwards quickly. Yeah, you got to really work on your gut. My guess is it's not just in your environment, but it's also in your digestive tract as well. Immunoglobulins, sealing up the gut lining, products like Moducare, which help improve, blunt lipopolysaccharide production. After we book an initial 20 minutes, sure. Can we become an established patient? Sure. Yeah. I mean, I just have people that return and we just work through these issues, and plus my whole team. Patient then join. Yeah. So what I recommend is, we're sort of when you look at our Beyond Mold model, to me, it's an access model, but one that requires a whole team. And so I keep my fees as low as I can, and I do these 20-minute visits. But then you can also join our $99 per month program, and you basically get access to all of us. So you can message us as much as you want. You can get questions on your health answered, questions on your home answered. My two sort of go-to experts are Lori and Michelle, but then I'm behind them, and we have experts behind us as well. We have an entire team available to people. I mean, I think it's one of the best deals out there when it comes to this stuff because, a patient that's informed and armed with good data and good information will make all sorts of great progress. That it's not just about following a protocol, the CIRS protocol or that protocol, this protocol. It's about where are you and how do we move you forward? And, a lot of people need that support and that interaction. So we built our model in a way where I'm available, my whole team is available, easy peasy. And, we did this on purpose. We have the best experts in the world, bar none. I really believe that. I know I'm biased, but I really believe that when it comes to this topic, our circles of experts, pharmacists, physicians, home experts, health experts, you can't believe who sort of stands behind the entire Beyond Mold ecosystem. It really is amazing, and I'm very proud of that. And we've tried to keep our prices down so that basically anybody could enter and get the help that they need. It's a big deal to me because I know how much people spend. They go to these fancy clinics, they have to spend thousands of dollars, and you get kind of one perspective on things. We're trying to break the model in that regard. We want you to have access to experts, but we don't want you to break the bank. And so that's really important for all of us. Let's see. Why would someone with HLA mold haplotype who supposedly is in the 25% to not make antibodies have high IgG antibodies on mine? Yeah. So that's my point. You may have missed it earlier, but the HLA, to me, if you look at the data on HLA, it says exactly the opposite of what sort of the CIRS model says. In all the diseases where HLA is important, people develop antibodies robustly, and in fact, they're at risk for autoimmune conditions. So what you're saying, Kara, is actually dead on for what we think HLA engenders. And so this notion that HLA in the mold side of the story keeps us on the innate immune system and we don't produce antibodies doesn't really seem to fit. So, kind of take that as it were, but that's what the science says. Is endometriosis in the suite of CIRS impacts? I think so. I think, all the hormonal disruptions, we see elevated estrogens, low progesterone, which can sort of be an underlying feature of endometriosis, which is also an inflammatory condition. And so, I think they're related to some degree. Multiple chemical sensitivity sick building syndrome, very traumatic because no doctors treat them. That's true. You offer services to help have avoidable chemicals, but we continue. Yes. So you can just come to the Beyond Mold website. As I said, You can sign up for our $99 a month program. You can ask all the questions you want. You can get appointments with me. You can get appointments with my colleague Larry, who's an expert for the home. Are you a fan of coffee enema? Yeah, but I think you can overdo coffee enemas too. You can really strip out your glutathione if you do too much coffee enemas. Can you treat in New Hampshire? Yes. So are you limited to certain states? Two things. Number one, I still have like 25 state licenses, including New Hampshire. So I'm sort of free to move about the cabin. But in addition to that, in our Beyond Mold platform, we have a 50-state telemedicine platform. So if it's a state where we just need to get someone labs or prescriptions, we can do it. We actually cover all 50 states with Beyond Mold, either me directly or through our telemedicine platform, which I'm thrilled by, actually. What are your thoughts on using Genova Diagnostics for testing mitochondria? It's not nearly what we have access to right now. There's a whole new world in terms of mitochondrial testing. And again, we've gone from some bench science to bedside recently. And I'm thrilled that I have access to that kind of testing. Do you think everyone needs a GENIE? Not everybody. Not everybody. You're welcome. You're welcome. What limbic retraining system is free? Why do they cost so much? I don't know of any that are free. But DNRS is good. Gupta is good. They're not that expensive. Are there any alternatives to cholestyramine that you recommend for occasional mold hits? Hard to get prescription for cholestyramine from Jersey. You can actually come to our Beyond Mold website, and you just access our telemedicine platform, and you can put in your information through our telemedicine system. You don't even need to talk to anybody, and we'll have a physician review it and then send you the well call. No problem. So whatever state you're in, we can cover it if you need a binder, prescription binder. Are there any alternatives to cholestyramine that you recommend for occasional? Oh, sorry. What can you do for severe constipation? Well, it depends. So there's a few different ways that I deal with this. And so there's some traditional herbal therapies like iberogast, and even erythromycin can be a pro-motility agent, in addition to obviously pro-osmotic agents and fiber and magnesium citrate and those sorts of things that we really work to kind of get things going. Turkey rhubarb is really good for constipation as well. Here's the interesting thing. Sometimes the constipation is from the disease itself, that the gut is so inflamed from the exposure and the CDR1 and the CIRS idea that actually, ironically, taking a little bit of a binder gets the constipation moving. If I had a nickel for every time I saw a patient who said, gosh, I'm so worried about my constipation, I want to start a binder, but then I encourage them to start a little bit of a binder, they're like, oh my gosh, I'm moving my bowels. So sometimes as we all know, this world is opposite world. And so I would say just be mindful, but sometimes actually taking a mild binder works really well in that situation. Let's see, losing focus and having a hard time finding the right words during conversation. What would you, well, talk about the impact on the brain. I mean, I talked about in terms of its structural issues, but this is a brain on fire. Mood instability, memory loss, loss of concentration and focus. There are at least 150 studies in the literature looking at the impact of mold exposure on the brain. It is profound. You have every right to feel like your mind is in soup. And, I think that's normal, which is why, you got to be on a binder. You got to make sure your drainage systems are working. And, we do all sorts of things with phospholipids and, bitters for bile flow and, things for the brain like RG3 and other stuff to make sure we try and get you as sharp as possible. Do you guys help with healing the gut if the gut is a big piece? Oh, trust me. When you look at our phased approach, we want you to fix the inflammation and exposure. We then go to the microbiome and dysbiosis and pathogens. Then we go to the gut. And we do a whole thing on the digestive tract. We look at the microbiome. We look at leaky gut. We look at food. You can't get better with this illness if you don't address the gut. Period, full stop, end of story. And I really believe that if you just skip over the gut, think about the gut-brain relationship. And it goes in both directions. So again, this is not a one-size-fits-all. You can't just take a few medications and hope for the best. You got to deal with the gut. Every one of my patients knows at some point I'm going to measure their gut and measure their food and make sure that we get their gut right. Let's see. How long does one take well call? Well, it really depends on exposure. Are you passing the visual test? Are you having re-exposure events? That's a hard one to answer. What testing do you recommend to understand if spike protein reservoirs are a factor? Well, that's when I go after antimicrobials. I probably do ivermectin, LL37. Those are the, I'm going to go after that. Thank you for sharing all this info. Thanks for being a mold guy. Yes, I'm in this with you. And, I'm trying to bridge the gap between what's the science and how do we get people better. And that's not an easy thing to do. It's a bit of a trick to say, this is where the most advanced science is at. This is where the most precision medicine is at. But then how do we translate that into sort of practical application? The toolkit is pretty big. But again, if there was one lesson, it's order matters and sort of figuring out where you go in terms of what you need. Pathway driver for severe sudden PEM crashes. That's CDR2. You need to rebuild your mitochondria if you're having crashes. Do I offer will you offer consults or education to Shoemaker trained practice? Yeah, I run a whole course at George Washington University to train practitioners in this broader approach. You're welcome. You're welcome. All right, I think I'm kind of getting the feeling that maybe. Oh, and you're welcome, Farisha. Thank you so much for your time, and thank you, the team. This is amazing. You saved my life. Well, it's to see you here with us now, and to know that what your journey was. It's why we do what we do, and it's why we built Beyond Mold, and it's why I want to answer all these questions and help you guys. So I know we're running way over. I mean, my goodness, this is almost 2 hours, and most of you are still here. I can't believe it. You guys are amazing. I mean, I could do this for longer, but I feel like I'm going to just, you guys are going to get wasted. So if you want, we're going to continue to do this. We'll do mini presentations. We'll go into different areas of the science. I'm going to start bringing on the rest of my team in these subsequent meetings, and then we'll have lots of questions and answers. And as you can tell, we've been on the front lines for a long time, so there's not much we haven't seen. I hope this is helpful. And I realize, the answers can be somewhat brief, but I promise you, we're not going anywhere. And this can be just an ongoing conversation. I'm happy to sort of do as much as I can. My team is going to do as much as we can to support you guys as you're going through this journey and this process. We want you to know you're not alone, and that we have this community that we're building. We care about you. We love you guys. And we're going to figure this thing out. It's going to take some time, but we're going to figure this thing out. All right. Well, I'm going to say goodbye, send you all a big hug, and we'll do this again in another few weeks or so. Okay. So wish you guys all the best, and just know that we're here for you. And if you need anything, just don't worry. Just reach out, and we'll do what we can to help you. You can find us at Beyond Mold, and that's obviously where our platform is. And again, thanks to my whole team. I've got an amazing team with Michelle and Lori and Scott and Colin and Carly and Larry and Jim and Praja, and the list goes on and on. I just feel blessed. And so again, thanks to everybody for doing this, and we'll see you in the near future. So you guys take good care.